The first treatment option that should be considered for this patient is anti-IL-6 therapy with siltuximab. This is the only FDA-approved therapy that has ever been tried in a randomized controlled trial for idiopathic MCD. It's proven to be safe and effective in a portion of patients, so that really should be the first line of therapy. In this patient, he had a very nice response to siltuximab. He had a nice response where he went from being on a ventilator, continuous dialysis in the intensive care unit, to beginning to improve, and he improved gradually to where he was able to be discharged from the hospital. Unfortunately, this patient relapsed 6 weeks after discharge from the hospital. This highlights to us just how complicated and complex this disease is. This patient had borderline elevated IL-6, yet IL-6 neutralization really stopped this disease in its tracks. Yet even while on IL-6 neutralization therapy, the disease relapsed. And so this just kind of uncovers that this is a complex disorder. It's not as simple as was previously thought, that this was an IL-6 driven disorder purely. This is a complex inflammatory disorder where IL-6 plays an important role and clearly was a linchpin during his first episode because neutralizing it resulted in remission. But with this patient relapsing 6 weeks later, we had to immediately start thinking about additional treatment options. Cytotoxic chemotherapy rose to the top of that list because of how quickly this patient deteriorated. And in Castleman disease, as with many disorders, particularly including malignancies, the most sick patients often require the most intense and aggressive therapies. So immediately when you see a patient going downhill like this patient, we've seen him crash quickly before, we've seen him experience multiple organ failure, and he's experiencing multiple organ failure again. So in our case, we felt it was important to be very aggressive and to use cytotoxic chemotherapy. Unfortunately, he didn't have an immediate response to the chemotherapy, but he did respond. And now we are looking at a whole host of what you would consider second-line therapies to hopefully either in addition to siltuximab or in place of siltuximab to keep this patient in remission. Additional therapies can consider, or it could include Cytoxan, etoposide, rituximab. Those are some more classically used drugs, but also more recently there's data suggesting that additional immunomodulator drugs like anakinra, which blocks IL-1, or like sirolimus or cyclosporin, which prevent T-cell activation, that these drugs have also been used effectively in Japan and in the United States. So it's important, as I said before, to think about idiopathic multicentric Castleman disease as a heterogeneous disorder where interleukin-6 blockade works in a large percentage of patients, but in the patients where it doesn't work, you really want to think about what subtype does this patient have? Does this patient have Tafro syndrome? If so, let's look at the literature of what drugs are working for Tafro patients. And in the literature, tocilizumab as well as cyclosporin have been tried. Etoposide and Cytoxan have certainly also been used, and as I said, sirolimus as well. So unfortunately, there are no recommended expert guidelines on treating idiopathic multicentric Castleman disease, but there's only one FDA-approved therapy, and I think it's very important to use the one proven, tried and true FDA-approved therapy to start. And if there are any recurrences or relapses, as we saw in this patient, you look into the data and see what has been working for Tafro patients and immediately start thinking about second-line options.